Everyone, you should receive a handout from LIFA shortly with the information to collect CME as well. But just as a reminder, in order to get CME for the meeting, make sure that you text 66611 to the number listed here on this screen by 1 p.m. tomorrow, and then complete the evaluation by October 9th at beaumont.cloud-cme.com. We're able to offer continuing education credits for CME, and medicine CME, nursing CE, pharmacy CE, and dietetics CPEU. And as far as our disclosures, they're listed here. Dr. Ashman, who is, of course, co-director for these learning community sessions, has stocks in publicly traded companies. And with that, I will stop screen sharing. And we are very lucky today to have Dr. Jonathan Gabison here to talk to us about patient motivation. Dr. Gabison is a family physician here at the University of Michigan and is certified in obesity medicine. He was the clinical champion for Briarwood Family Medicine, one of our participating primary care physician sites, and he serves as a content expert for MCT2D. I'll hand it over to you, Dr. Gabison.
Thanks, Jackie. Good morning, everyone. Let me put this in. Does everyone see my screen?
Yes, but if you can switch presenter view and the other view, that'll be better. Right now it's showing speaker notes. Can do it. Yep, perfect.
Awesome. Thanks, Jackie. So I think this is a very challenging thought. Talking to our patients, helping them without losing our mind. We all have patients who are very challenging, and how do we help them make positive change, but also do it without overwhelming ourselves? I have no disclosures. Our goals for today is to learn about motivational interviewing skills, identify and help patients who are ambivalent or not ready to change, understanding motivation and why we struggle, why our patients struggle, and then helping you, me, as healthcare professionals feel better about our relationship with patients who are not going to change. We're going to do this through 3 cases. The first case, we'll talk about motivational interviewing skills. The second case, we'll go into some neurochemistry behind motivation. And then the third case, we'll look at some self-reflective approaches. So the first case, this is actually a patient of mine. He is 49 years old. He is a type 2 diabetic with end-stage renal disease on dialysis. His BMI is over 40. He has a history of a failed kidney transplant. His A1C has fluctuated since I've met him between 10.5 and 14. In February, he suffered a vertebral fracture and he has a lot of severe back pain. There's not many interventions that we can do other than pain management. He works as a janitor. He lives with his wife and has 3 children. Unsurprisingly, he's overwhelmed by his medical burden. He has dialysis 3 times a week. It's difficult to keep his medications straight. His pain is intolerable at times. And it seems like each time our appointment is focused on something else and his diabetes gets kicked down the road. But of course, me being a Michigan MCT2D content expert and have my quality metrics, one of my major goals is to get his diabetes in check. So every time it's challenging to talk about his diabetes. So as a group, you can enter this into the chat. Try to jot down, any sort of feelings you have about this patient or how this kind of situation might make you feel. Under pressure is the first one that I see. Overwhelmed. Frustrated. Definitely frustrated. Mad that I do everything right. limited. And especially when we have only 20 minutes, or even sometimes a little bit more than that, but there's so much that we have to handle in this appointment. How are we going to get this all done? Wanting more resources for our patient. This kind of pressure gets put on us, and then it might lead us to handle the situation a little bit differently. Thank you. So what some of you might be thinking or describing are causes of discord. Discord is when there's dissonance between us and the patient. Some thoughts or feelings that can lead to discord or dread, dread that we have to deal with this, dread that we have such limited amount of time, depletion where we're not getting anything done, fear that we can't help the patient. It can lead us to a more directive style in counseling. We need to put on our expert hat. We need to tell them what to do. We over-explain things to the patients. We use scare tactics. We might get ahead of where the patient is at and where they're not ready to be. There are different forms of communicating. Directing, like we just discussed, is instructing without empathy. Following, on the other side, is just listening, showing sympathy, but not really giving any guidance. And then guidance is where we want to be, where we're listening, we're empathetic, and we're helping our patients move in a direction in alignment with their goals. And this brings us to motivational interviewing. So motivational interviewing is a style of counseling that you can use to try to help patients move towards their goals and move towards change. It's a conversation style in which the patient is voicing, they're the ones voicing all the reasons for change instead of us, instead of the provider. For me, when I practice motivational interviewing with the patient, I feel a shift. I go from instructing them and feeling the responsibility for the behavior change to coaching and supporting them into making the changes themselves. And it's about accepting the patient where they are. And it's not an easy thing to do, right? So we're trained not to do this. In fact, we're trained to have answers. We're trained to solve problems and to solve problems quickly and acutely. When this manifests in conversations, we often try to convince or persuade our patients to do the right things. And we want to give them the right information and educate them about risks and strategies in order to make the correct decision. If we really want to accept our patients where they are and guide them, and guide them towards change, we need to resist the urge of pounding them with information. The technical term for this is the writing reflex. If you can recall any conversation in which you felt you were tugging and pulling with a patient, like a tug of war with a patient, you felt this feeling, right? This writing reflex where you need to correct them. The spirit of motivational interviewing is about the relationship, right? It's the spirit and how we are going to bring ourselves to the conversation. I felt stressed about the patient. I don't want negative outcomes for him. Our partnership, we take off our expert hat, that we assume we know what our patient needs and trust that they are experts of their experience, right? Acceptance, right? If we push too hard, they will push back. And once we accept them, they are able to make changes. Compassion and empathy. The power of reflective listening is a learned behavior that we can learn over time, and that can help them move towards change. And then evocation. So evocation is empowering the patient where it comes from them instead of from us. That if it comes from them, they are more likely to change. The paradox of change is when a person feels accepted, they're going to be open to consider change rather than guarding and defending against it. But it's counseling in this style, the empathetic, collaborative, compassionate, accepting, non-judgmental, this just social niceties and kind of going to this like hippie style of counseling, or is there something else to it? And there is something else to it, and there's evidence that supports bringing this style with our patients is going to lead to good outcomes with our patients. So this is a really interesting study, and the reason why I'm highlighting this one, and there's several other studies, but I like this one because it looks at a very challenging group of patients, right? So we're thinking about children. And behavioral change in children is even more challenging because we're not just thinking about the children, we're thinking about the family dynamics too, and the family members and the parents. So this study tested the efficacy of motivational interviewing delivered by providers and dietitians to parents of overweight children ages 2 to 8, and showed how motivational interviewing can have statistical significant impact compared to the control groups who received usual care and usual follow-up. So I really like LA, right? I feel like we have a really good relationship. We connect on several different things. He is kind. He loves his family. I've tried to use these things to motivate him before because these are things that motivate me. So I'm trying to reach him through things that motivate me. I've offered him the resources and tools that I know about, and they haven't worked. But this time, so I had an appointment with him in August. This time it seemed things were a little bit different. So I'll kind of run through the conversation a little bit. His A1C was 13 in our visit, and I said to him, it looks like you aren't taking your insulin based on how high your A1C is. Why is that? And he responded by saying, I don't eat a lot. I don't know when to take it or not to take it because I'm only eating 1 meal a day. I feel tired all the time. I'm in dialysis. I have my pain, and I don't want to make any mistakes. And then I asked him about the mistakes. What do you mean? What mistakes? And that's where he gave me a little bit of insight that I didn't have before. He said, there have been times when I take my insulin and at night I wake up with really low blood sugars. And this was something different, a piece of information I didn't have before. And so now we can use some motivational interviewing tools that can help him lead us with change. And so one that I think about is the readiness ruler. So the readiness ruler can be a really good tool. So how does this work? Step 1 is ask them where they are on the likelihood they will change from 0 to 10. And step 2 and 3 is asking them why not 2 points down and why not 2 points up. So for him, asking him about importance. So we would ask, how important is it for you to change your insulin use? He put himself on a 3. So once he gives an answer, we can use the readiness ruler to evoke some reason for change. If we ask him why you picked the number 2 less, so why did you pick 3 and not pick 1? I know my blood sugars are important, doc, but there was this one time I went really low overnight and that really scared me, and I don't want that to happen again. Why? That's really scary, but why? What do you think it would take for you to go from a 3 to a 5? Knowing that the low blood sugars wouldn't happen again. The hypoglycemic events, this is something I didn't know before. This is something he didn't tell me, even though we've talked about this stuff many times. The low blood sugar events were something that has been preventing him from taking his insulin appropriately. And so now we can change what we're asking. We can change the tools we can give him, and we can offer him more information, like using a continuous glucose monitor. So we'll go over some additional information, but I just wanted to put this slide here for some additional information about motivational interviewing. You know, we should always ask for permission. We should try to establish a relationship with our patients. We should always focus on how to change, right? Not necessarily on instructing our patients. Asking open-ended questions, giving affirmations, showing that we're listening by reflecting back what the patient has said and trying to summarize. The readiness ruler is a good tool to use to see where they are, and another tool to use, reflective listening. And then, you know, asking for permission to offer advice, and I'll go into that in another case. Okay, case number 2, RG. So this is a 43-year-old male. His BMI is 42. He works as a clerk. He has fatty liver. He had newly diagnosed diabetes, and he is an ex-smoker. He was referred to our weight management clinic, but he didn't realize that he was coming to a weight management clinic, and expressed that he didn't know why he was at this appointment. During our conversation, I like to do a 24-hour recall, diet recall, to understand how they're eating. And he expressed a few different things. So he works nights, and he gets whatever he can in the hospital. So specifically, he orders pizza, he'll eat a burger and French fries, and then he goes home and sleeps. To stay up, he drinks 4 Mountain Dews a night, 16-ounce bottles. When asked why, he expresses the caffeine. Mountain Dew is the only thing that keeps him up overnight. I already got rid of one advice. I am not going to get rid of another. And what my thoughts are is there is no part of this that will go well if you keep drinking 4 Mountain Dews. Too often our patients, ourselves, our society, we think that the reason people cannot change boils down to their willpower. And, you know, maybe not all of you think that, maybe some of you do and some of you don't. I know that I've experienced that. I've experienced that for myself at different times in my life, where I feel like I struggle with certain things because of my own willpower issues. So the goal of the next few slides is to understand why our patients are struggling to make behavior change, and to understand that it goes beyond willpower. So motivation is the process that initiates, guides, and maintains goal-oriented behavior. It involves biological, emotional, and social forces that activate behavior. Dopamine is the neurotransmitter that governs this motivation. So if you take genetically engineered mice that are unable to make dopamine, they will not seek out food, and they'll starve to death, even if you put food right in front of them. If food is placed directly in their mouths, they will chew and eat the food and seem to enjoy it. By inserting a probe into a rat's brain, neuroscientists can demonstrate that dopamine is released in the brain in response to a conditioned cue, in this case, the light, well before the reward itself is ingested. And the reward here was cocaine. So here, if you're looking at this timeline, and try not to lose me on this, because I promise you this gets really interesting. But if you look at the timeline here, the curves here going along the timeline is the amount of dopamine levels. So the pre-reward spike is in response to the cue. This is the anticipatory pleasure we experience when we know good things are coming. After the cue, the brain dopamine firing dips not just to the baseline, but below the baseline. This is how motivation works. This dip below the baseline motivates us to seek out the reward. Dopamine levels below the baseline drive cravings. And then the cravings translates into purposeful activity. And in this case, to seek out the cocaine or the drug. Once we get the anticipated reward, the brain dopamine firing increases above the baseline. And that's where you see that big spike at the end. And this works the same with anything, right? So increasing dopamine is triggered by your desire for everything, right? Anything. So if I say I really want a Reuben sandwich, right now I'm thinking about that rye bread. I'm thinking about the sauerkraut and I forgot what kind of meat's a Reuben sandwich, but I'm thinking about it. I'm thinking about the taste. And now my dopamine is starting to rise, right? And it comes down a little bit. And now I'm starting to have that that release in anticipation. And then that increase in dopamine relates to our desire and propensity to move or act towards that object, that desire, that want, that sandwich. But what if we don't get that reward we anticipated? The dopamine levels are going to fall well below that baseline. We can see similar peaks and troughs with dopamine, not just with drugs or addiction, but with general behaviors. And these lead to suffering, to pain, to depression, to mood changes. You know, I recently began to understand this more when thinking about my own imperfect habits, but also with my oldest child and specifically with screen time. So I was reading the book Dopamine Nation in February, March time. And it was around this time period also where I was learning a lot about this specific dopamine related motivation. My oldest child was pandemic related, was probably getting way too much screen time than he should have been getting. And he would have these emotional collapses if he couldn't be having screen time. So if he wasn't playing video games or watching TV, he would be so bored that he would collapse, and it would lead to everyone experiencing his mood swings in the house for about an hour or two. This led us in the house to really putting a prescription around screen time and limiting it for everybody, specifically around certain times, and it was very, very helpful for everyone. Then one Friday, he was sick, home from school. My wife and I are working. He got more screen time than normal. The next day, so that kind of simulates this first picture where he got this big spike of dopamine. The next day, he got a little bit of screen time in the morning. And then I was like, hey, let's go do something else. Now, it wasn't as much as it was before. His brain was expecting a lot more. And all of a sudden, when he couldn't get that same amount, he had this emotional collapse again. He had this big dip of dopamine. And it was the first time when before I understood the system, I would get so frustrated at him for having this emotional collapse because I thought this was on him. But then I realized that this is a lot more than this work. This is not his choice. This is something that's going on inside of him, inside his brain, that he doesn't have a choice over. I hope I didn't lose you too much in those weeds, but I felt like that changed the way I saw this kind of process. I saw it in my son, I saw it in myself, and now I'm able to see it more in my patients, and I'm able to see and explain things a little bit differently. But the idea of bringing this up doesn't necessarily mean that you have to talk about, your problem with behaviors has to do with your dopamine levels. But I think it's really important to see it for what it is, that sometimes we have these difficult circuits of behavior, right? Understanding that this is not necessarily our forebrain talking, right? But these compulsive behaviors are part of our innate lizard brain or hypothalamus is governing these kind of behaviors. And many people who try to make health changes get in these cycles where they try and then they get stuck and resort back to these bad behavior cycles. So they feel like they're a failure and their willpower is weak, but it's not necessarily about will. So what this dopamine system tells me as a person and as a physician is that the brain processes behind these compulsive, repeated, unhealthy behaviors are more complicated, that they involve parts of the brain where we don't have control. So taste, sugar, feel of the food, texture of the food, relationship with the food. These are all things that will lead to dopamine pulses for individuals. Hearing it is not a willpower issue, but a neurotransmitter issue can be helpful for some patients in moving towards change, or at least empowering them to think a little bit differently about the reasons why they're stuck. So back to this case. On the one hand, before giving advice, right, I want to make sure I've listened and heard him correctly. So on the one hand, caffeine and sugar is keeping you up all night, and you are really worried about giving it away. This helps you give up smoking, and you are worried if you give up Mountain Dews, you will start smoking again. On the other hand, you're really worried about your liver disease, and we just talked about how toxic sugar is for your liver and how important it is to make big changes for your health in your liver. Good reflections, reasons to stay the same, reasons to change. Part of him wants to change, but he has behavior patterns that he's stuck in. So this is another motivational interviewing tool: elicit, provide, elicit, right? So what do you already know about risks of sugar and Mountain Dew, right? So asking the question and letting him answer you, and then providing a statement. So may I tell you about some of the medical information about sugar and insulin that I think is important to know? What do you think about that information? So this allows one opportunity for you to teach, and two opportunities for you to engage in question answering with the patient. What questions, if any, do you have about some of the negatives of these drinks have on your health? Could I share some information that other patients found helpful? How might you have worked? How might you work that information into your decision? And then another good tool are magic wand questions. So, what will happen if you don't do anything? Like, what will happen to your health if you don't do anything? Let them answer that to you. Let's see if we can find information that we can work with. Or let's say you're better in 6 months. What did you change? Or what are the three biggest reasons you want to make a change? These are ways that you can get information that can allow us to make smart goals with the patient to help create change. So this patient ended up not being a complicated person. He was able to start making dinners at home, which was a big change for him. And we talked a lot about the Mountain Dew and sugary drinks, and we were able to replace that with coffee, actually, and it worked out in our favor. He was also started on a GLP-1, which he wasn't able to have access to before. I just want to mention that there's been interesting research that has been coming out about the GLP-1 receptor agonist, specifically semaglutide, and that especially interesting in this like dopamine system pathway, where we see studies where it's decreasing alcohol intake in people who are using it for weight loss or for diabetes, for example. People are less interested in eating foods, having less cravings. And so the thought is that it's having impact on these reward centers of their brain. We're still learning a lot about these medications and other medications that act on the hypothalamus. But I think it's important to think about when we catch on to these addictive kind of food patterns, and seeing if medications can be helpful at times when we're trying to work on behavior change. So SMART goals, in case you're unaware, so they are specific, measurable, acceptable. You don't want them to be too ambitious. They're realistic, and then they're time bound so that we can check in on them. Okay, so case 3. So this is a poorly controlled diabetic. This is one of the ones that got emailed in. So poorly controlled diabetic. They use a continuous glucose monitor. They are on insulin and GLP-1 receptor agonists. They are not very active. They have poor motivation. They have a lot of knee pain. They're not eating well, and they're also not taking their medication. So how do we handle a patient who doesn't want to do anything? This is really, really, really hard, and this is the challenge. The challenge here, and with some of the other cases that were sent in, is that there isn't really a quick and easy fix. Behavior is really complicated, and each person is different. And so I wanted to use this case to highlight that this is hard for us too. I have patients like this where I find it very challenging. And so how can we help our patients, give energy to our patients? And it's hard to see that they don't change or that they don't improve. Like, how can we keep going into it? So I wanted to talk a little bit about the thought model, right? So the thought model is a coaching tool to understand how the brain works and how behaviors are formed. This can be an effective tool for us as providers taking care of patients to check in with ourselves, right? So, and we can also use it and we can also teach it to patients if we deem it useful, although time would be a challenge, but we can also teach it to patients to help them think about change too. So the idea here is that circumstances prompt a thought, this thought creates a feeling, the feeling leads to an action, and that creates a result. So what does this mean? Let's take this example, right? So the circumstances are facts. They are neutral and out of your control. So in this circumstance, I have 36 patients scheduled in my clinic today. There's not anything that you can do about that today. You are going to have 36 patients on your schedule today. You're not going to be able to cancel all of your patients. You're not going to be able to run away from them. But this leads to thoughts. It might lead to several thoughts, but I'm going to select one of them. I am never going to finish clinic on time. When you have this thought, this is going to lead to different kinds of emotion, different kinds of feelings, specifically creating a feeling of overwhelmed. Feelings are interpretations of emotions. They start in your brain and they travel outward. They're generated by your thoughts and not by your circumstances. So you're feeling overwhelmed, not because of the 36 patients. You're feeling overwhelmed because you feel like, because of the thought, I am never going to finish clinic on time. When you're overwhelmed, then these actions start to happen. You start to ruminate, you start to procrastinate, you start spreading yourself thin on different tasks, and eventually the result occurs, I do not finish clinic on time. So let's go back to that patient GT. There's a lot in that circumstance that we cannot impact outside of our appointment. We're not going to make them, we're not there making them take their medications every day. We're not there filling their pantry and their refrigerator with the proper nutrition and making them make the right choices. We're not there making sure they're being active. We cannot do all of those things, right? But coming into the appointment feeling or having thoughts that we are unable to impact can cause some issues, and we'll talk about that. So I kind of went over this already. So interpretation, feelings are interpretations of emotions. They start in your brain and travel outwards, and they're generated by your thoughts and not your circumstances. Actions, so something we do is a behavior, something we don't do is an inaction. So with this patient, what do we do when a patient doesn't want to do anything? I'll take some audience participation on this one. What thoughts do we have in these challenging encounters? Like, you can answer in the chat. If I haven't lost you all already. Oh, that's a great one. Why aren't they accepting my help? I love that one. I feel like I hear that and I think to myself, there's so much that goes into why aren't they accepting my help, right? We become healthcare people, right? Because we want to help people, right? We're in this world to help people, and it's so frustrating when we try and we try and we try, and there are these people that are just not accepting it. Like, how can we change that? The frustration that builds up with that is just overwhelming. Wow, a lot more messages. 1 second. I might as well give up. Worried about the consequences for the patient. I'm never going to be able to get this patient to want to change. What do they want to get out of the visit? I don't really have the tools to help this person. Not sure I can do this anymore. They do not understand the importance. Can be frustrating but rewarding when we can get them or ourselves to work together. I love that one, Sharon. They feel they know what to do, but they don't do it. I can only do my best. Or I hear my mom had it, so I know what to do. I love that. Thank you for all of that insight. Maybe today isn't the day yet. So when I think about this kind of circumstance, right, and it really does come up a lot, right? I think it's important to pause, offer reflection, self-reflection, and think about our emotions going into the encounter. And then, we see this patient a lot. They're not doing well. We probably have several visits with them. Things aren't working out. So let's be honest with them, right? Sometimes I feel I'm not helping you, right? I don't think this is going well. I want to spend time today addressing what would be most helpful. And then ask them what I can do to be helpful, because clearly what we've been doing hasn't been working. Or when you leave this encounter, how do you want to feel about your plan? Or, sometimes I do this more than other people, and I think different people have different levels of comfort with this, but offering a personal connection too. Sometimes I struggle too. Sometimes I have my doubts too. And that can help create an additional connection or allow them to move further along in the process. I want to open up the floor a little bit before we go into more cases. Jackie, how much time do we have?
We have till 1 p.m. when the meeting wraps up. So however you want to divide that time, Dr. Gabison.
So I wanted to, there was a few more cases that got sent in, and we can go over them one by one, but I wanted to open up the floor a little bit because I feel like I gave a lot of information and I want people to have a chance to kind of reflect on some of the things that I brought up, but also if they have direct questions to anything that I talked about. And then if no one has any questions, we can go over some of these additional cases. I'll give it like another 30 seconds. If no one wants to ask anything, I'll just start going over the additional cases and my thoughts behind them, because I thought they were very thoughtful.
All right, are you looking for questions in the chat or verbally?
Either or. Verbally would be nice. It's
okay. I'm sitting here trying to type, but I can't type it all that fast.
So better verbally.
Okay. So when I'm doing goal setting with patients, I try and help them problem solve and think through some type of short-term non-food reward that can help improve their motivation. We all like to do things that are rewarding, that we feel good about ourselves doing. But using the dopamine illustrations that you gave, where would you suggest the patient incorporate that type of reward? Should they do it at the beginning, or should they do it at the end to kind of reinforce the change, or do they need it at the beginning kind of before they get started to help move that curve along?
Such a good question. There was a slide that I took out because I thought I was going to go way too much into the weeds on this. But so, you know, when you start getting the craving, right? So it's kind of, let me think if I have the right words to describe this. It is, so I'm going to reflect on my own experience here. So I used to be a smoker, right? And one of the times that I quit and I had success for a long period of time is I replaced smoking with exercise habits, right? So whenever I had a craving for smoking or for a cigarette, I would go and walk around the block, right? Or I would do 5 push-ups, or I would do something like that. So it's replacing the craving with a very specific kind of activity. Or like a classic behavior example is like, I didn't want to do this presentation. I did not want to make these PowerPoint slides. And so I keep that is the like the task of the not wanting to do something. And so you procrastinate by doing other tasks that seem worse, right? And that makes you do the thing that seems easier. Does that make sense? Did I answer that correctly?
I think that's a helpful thought.
I think with patients, I think, do you have a specific kind of situation in mind?
So I'll use a personal example as well. After my mom had passed away, I found myself every time I went anywhere, grocery store, gas station, didn't matter, I would buy a candy bar. Mm-hmm. I did not need the candy bar. Okay. So at one point, what I did was I told myself that if I didn't buy the candy bar, I would take that $1 and I would put it in a book fund. I like to read. My husband hates books because they sit on shelves and collect dust. So it only took 7 or 10 good decisions and I could buy a book, something that felt rewarding to me. And if my husband looked at me cross-eyed, I would be like, I earned this book. You can't say anything about this book. But that reward came after following through on the action to make the change. Do you kind of see where I'm going with that?
Completely do. And I think that is such that is a really good motivational tool. It's using money specifically, like you hear that with smoking also, right? You take the money you save on those packs of cigarettes, right? And you put that into a fund, right? And then you use that money at the end of the month to buy yourself something. I think that works for some people, right? And it doesn't work for other people, right? And so I think it's something that you can offer, but that person has to find what is that motivating thing for them to give up that desire, right? And I think you have that insight of drawing the connection of that candy bar and your loss, right? You see that connection, and I think that is the type of thing that a really good provider can draw a connection between someone's behavior and the why behind it, and drawing that connection can empower them to start seeing ways to change. Does that make sense?
Yeah, that's what I tried to do. I just wasn't sure, based on the little picture with our little rat, if you have to create incentive prior to that, you know what I'm saying? How do you do that? You know, the reward came after the decision not to buy the candy bar.
So
I'm just not sure how to get my patients ready to not buy the candy bar. Does that make sense?
So I think understanding the why, the connection of why they go for the candy bar. It's okay that they go for the candy bar, like to have like non-judgmental view, right? So let's start there. The candy bar is okay, right? But why do you do, right? And then when you understand that why, and you see it for what it is, and then you can start to create an environment around changing that behavior.
Okay, so more open-ended questions then.
Yeah. Okay, so any other questions that were worked on, or should I go through some of the additional cases? Okay, case one. So this one I found to be a really interesting case. So this is a patient who is on a CGM, but they seem to have an alcohol problem, and they would stop using a CGM when they drink alcohol, and ended up in the hospital because of this. The provider reviewed nutrition, physical activity, and alcohol use multiple times, and the patient is not ready to change. I think one of the challenges behind getting these vignettes is that it's hard to understand every little aspect of what's going on in the patient's case. But the first thing that I think about with this patient is alcohol use disorder, right? And so if they have addiction tendencies and they're addicted to alcohol, knowledge and isn't necessarily going to be everything behind it, right? So you know, it's not just behavior change that's going to solve someone who's addicted to heroin, right? Sometimes they need Suboxone to help them, right? So maybe they need something in addition for their alcohol use disorder, right? Especially if that seems to be what is causing the issue. But I would have a motivational interview discussion about alcohol use, right? And then, you know, I think about tools like the readiness ruler. I think about trying to understand where they are and why, and what are the barriers for them to changing, right? And then seeing if you can offer them additional resources for that specific issue. This is where I wish this wasn't on Zoom so I could see the faces in the room, because I don't know. I don't know how the room is reading my answers. This second case, so this was a patient who is no longer testing their blood sugars. They were done testing their blood sugars because they did not care how it would impact their health. They were first diagnosed more than 20 years ago, and they were just tired of managing their blood sugars. So I'm not sure I'm not sure, again, about details behind this. I think specifically what medications the patient is on. But the first thing that I think about is if they're on insulin, I would want them to be testing their blood sugars. And I would move towards, I would offer them continuous glucose monitoring as a way to not have to do the finger pokes. So I would also want to know what their issue is with testing their blood sugar. I'm assuming it's poking their finger multiple times a day, because that doesn't sound like a pleasant thing. And seeing if wearing a continuous glucose monitor 10 days at a time or 14 days at a time would be something that is more comfortable for them, or something that they would be more willing to do. If not, is there a way that we can get them off of medications that cause hypoglycemia and move them towards the medications that don't cause hypoglycemia, like GLP-1, SGLT2, metformin, just so that we limit the opportunities for hypoglycemia deaths. This case is several patients, so a provider that has several patients that struggle with motivation to begin changing their dietary habits due to cost barriers of purchasing healthier foods. I hear this one. This is one of the most challenging parts of our job, I think, because those foods that are cheaper are the ones that are going to cause those big dopamine spikes, because they are sweeter or saltier, or cause Cheeto fingers, or have umami, or do things that aren't the best for us and cause those neurotransmitter releases. Plus, they're heavily processed and all of these sort of things. The MCT2D website, the Michigan Collaborative for Type 2 Diabetes website, does have resources that tries to help with this. The Jumpstart blog has resources that try to help. I think that is the best I can do from this standpoint. Sometimes I talk to patients about how some of these foods lend to making you feel hungrier more, but it's so hard to kind of make these connections with patients, especially if we're trying to make these kind of incremental changes. Another frequent barrier that occurs is initiation of physical activity in patients with limited mobility or chronic pain. So, one of the most in terms of physical activity, like from 0% to 100%, if we put everyone on where they are on that kind of scale, the most value comes in terms of longevity and benefit is if we move someone who is not doing anything to that second quartile, which isn't that hard, is not that much movement along the scale, right? So what does that mean, right? So if someone is not willing to do anything, I don't tell them that they have to start doing 30 minutes a day, 5 days a week, right? I think that is overwhelming for most people. I will say, if you don't feel like you can do anything, just stand up during commercial breaks. That has value. If you are standing up and moving around, okay, let's walk around the house. You don't have to go for 30 minutes. Just walk around your house or walk around your apartment, or walk up one flight of stairs and down one flight of stairs. Small amounts of activity have value, right? If you can't do those things, bring something by your chair, like light weights, and do those things, or print out chair yoga exercises that you can do. Again, we have this mentality that we need to be doing 150 minutes of exercise, and so our patients think that that's the only thing that has value. And even a minimal amount of activity is going to improve their A1C and improve their sugar levels. And so we should start them there. And you'll see, if they walk for 5 minutes, they're going to start walking for 7 minutes and 8 minutes and 10 minutes because they're already out, right? So just starting at something, right? If they're not doing anything, do it once a week. If they're doing it once a week, do it twice a week, and start moving up slowly. I think we're all out of time. Is there any other questions that anybody has?
Thanks so much, Dr. Gabison. That was a great presentation. We really, really appreciate you sharing your expertise on this with the collaborative.
My pleasure. Thank you, guys.
Thanks, everyone. We will get these slides and the presentation posted, and don't forget to submit your evaluation for CME. Thanks all. Have a great rest of your day.